Welcome to September's AOT Learning Network webinar or web chat, sorry, for AOT monitors. Thank you everybody for joining. My name is Brooke and I work as AOT Implementation Manager on TAC's AOT implementation team. And first, I just want to notify everybody that we are recording this meeting and that it will be posted publicly to TAC's YouTube channel and shared with you as a resource later next week. So we're going to just start with introductions, beginning with the TAC team and then going in the order of how your squares appear on my screen. And so for those introductions, please share your name, location, role, and why you joined today. And I'll put that in the chat so you don't forget. And then lastly, just in the spirit of building community, we would really appreciate seeing your faces if you're able to go camera on. Alrighty, so I'm going to hand it off to Amy to introduce herself.
Good afternoon, everyone, and good morning to a few of you. Dr. Koyanagi, looking at you. My name is Amy Lukes, and my expertise is in mental illness and community mental health. I'm a social worker by training, and I've been on the team for 7 years.
Sarah?
Hey everyone, I'm Sarah and I am an attorney and I am on the AOT implementation team.
Jared?
Hi, everybody. My name is Jared. I'm our senior AOT advisor. I work on our educational and training resources for AOT programs.
Thanks, Jared. Alrighty, so we're going to do this Hollywood Squares style. The first person I see is Cindy.
Hi, good afternoon. I'm Cindy Simpson from Allegheny County in Pennsylvania. And I am really on here to try to get as much information as possible as we are hopefully getting closer to the kickoff of our AOT program here. We are still definitely in the developmental phases, so I'm kind of like a sponge, just taking in all the great experience and knowledge of this group that I can.
Awesome. Welcome, Cindy. Nick?
Hi, I'm Nick Schrantz, AOT Monitor in Butler County, Ohio. I've been in that role for 18 years, and I'm here because Amy Lukes tells me to be here, and I do whatever Amy Lukes tells me to do.
As do I. Good to see you, Nick. Carrie?
I'm Carrie Crane. I'm with the Johnson County, Iowa AOT program in Iowa City. I am here because I always show up.
Well, good to see you, Carrie. Chad?
Hi, I'm Chad Koinagi. Thanks for letting me come to this. I'm a community psychiatrist in Honolulu. We've had an AOT law for the past 10 years. Mostly it's effective for people who are kind of gravely disabled, homeless folks with severe mental illness. Although we have a law, we do not have an AOT monitor. We do not have specific AOT judges. We don't have a specific AOT treatment team. So we're kind of stuck now and floundering in how to make this go forward. So I'm just trying to learn from all you folks about how to incorporate all the key elements of a AOT program.
Amazing. Welcome. Thanks. Kelly?
Hi, everyone. My name is Kelly Proctor. I live in Howard County, Maryland, and I serve on the local Behavioral Health Advisory Board as a family member. My 30-year-old son, 10 years now, was diagnosed with a severe mental illness. And Howard County passed the AOT bill and legislation last round, but we too are in the whatever phase. My son got in trouble with the law April of 24, And I've watched the judge kind of implement AOT without officially naming it that and kind of put me in charge of his monitoring. So I'm here to kind of get information as well. So thank you all for including me.
Thank you for joining, Kelly. That sounds like a voluntold type of situation.
Exactly.
Devin?
Hi, my name is Devin Roos. I'm with the Terrebonne Parish AOT program in Houma, Louisiana, and I'm the program evaluator.
Good to see you, Devin. Jamie?
Hi, I'm Jamie. I am from Marion County, Ohio. I am the AOT monitor and I'm fairly new to my position, so I am here to learn whatever I can.
Welcome, Jamie. Karen?
Hi, everybody. My name is Karen Thomason. I work for Frontier Behavioral Health in Spokane County, Washington. We have a long-standing least restrictive alternative monitoring program with our county, and we are also just getting started with AOT. The west side of Washington has already started that work, and Spokane is coming right along. So I'm here to join. I will probably have to go camera off after a little bit as I'm traveling to another meeting, but thanks for having me. Happy to be here.
Welcome, and no worries. Margaret?
Hello, my name is Margaret Elmer. I'm in Douglas County, Colorado, and I recently learned that the local community mental health center is operating something they are calling AOT, but without the involvement of the court. So I'm planning to look into doing this. This is one of my to-do items on my list, and I haven't got to that yet, but I'm planning to get involved with that.
Awesome. Thank you, Margaret. And last but not least, Katie.
Hi, my name is Katie Yates. I am the medical records supervisor at Frontier Behavioral Health. I'm the supervisor for the team that will monitor AOTs for Spokane County here in Washington. And Karen Thomason on the call is my boss. So we're just trying to get some more knowledge and yeah, glad to be here.
Great. Well, welcome everybody. Thank you so much for introducing yourselves and for sharing. Um, so we kind of have a range of folks on the call. We've got a couple seasoned AOT monitors. We've got people just starting out. We've got people looking to learn. And so we have a resource to kind of assist with guiding today's discussion. But before we get to that, I really just want to open up the floor. I know it's often the case that you don't know what questions you have. But if you have any particular questions that you would want to raise, that the TAC team or your peers on the call could help answer, I want to give everybody a chance to do that and no need to be shy.
I guess for me, watching this whole process, is there an end goal with AOT? Like I am seeing advantages, like my son's in a PRP program and I see changes of learning. But as we all know, with a serious mental illness, that's not always gonna stick or last. So what is the end goal with AOT and the monitoring?
Nick, I saw you nodding your head.
I'm usually not very shy. The only thing I really want to say in this whole thing is to Kelly herself, since she's been the judge-appointed monitor for her son. But the whole goal of AOT is treatment, and the main suggestion I could make to you, Kelly, and this would fit in with any sort of AOT program in any state, in any county throughout the country. Everything about AOT is about treatment. And an AOT monitor or an advocate is you're pushing your, in your case, your son, in my case, we call them respondents. The goal is pushing them to treatment. And so I think the best thing you can do is keep deflecting your son to his treatment provider and keep advocating to the judge to hold, I guess, accountable your son's treatment adherence with that provider, because then you're not stuck when he says, I don't like this medicine or I don't like that therapist. You keep deferring and deflecting back to the treatment provider, assisting him and advocating for him if he's not getting the care that he needs, and then reporting that to the court. But again, it's always deflecting towards treatment provided by his team.
And how long does that, like his sentencing is at the end of October. So how long am I asking for that? Like how long do people typically, I mean, I'm in it for life. He's my son.
Right.
I mean,
different
court-wise.
Different states and different counties will have different protocols. In Butler County, Ohio, where I am, and I've done this for 18 years. I've had clients under civil commitment for 18 years.
Wow.
Because our standard is not behavior. It's not a time protocol. It's insight. Everything we do is driven by insight. And I have clients, I had one on Tuesday. We have our review dockets on Tuesday. He's been in our program for 18 years. He's not had a psychiatric hospitalization in 18 years. He's not encountered the criminal justice system in 18 years. You ask him what he does if the court was done, he says, I stopped my medication. So he doesn't have the insight to continue treatment without the court order and supervision. So it's all insight driven, not behavior. When someone says, well, he hasn't been in the hospital in a year and been in treatment, I don't think it's time to stop the court order if the insight isn't there to continue treatment without the court order. Now, I don't know what Maryland statute says. If your AOT is being driven by a criminal court judge, that judge has a limited time frame in which to have jurisdiction over your son. But hopefully, if Maryland develops their full AOT program, then I hope it's driven by insight.
That's a great point. Thank you so much.
So first of all, I can't help myself, but there is no sentencing in AOT.
Right.
There is the criminal court is not involved in AOT. AOT is a civil court procedure. And the end goal of AOT is, as Nick said, I want to split hairs with Nick just for a little bit here. And that is, there are some people who will never regain insight, but they may be able to connect their involvement in treatment with improvements in their life. They may be able to get that if I don't take my medication, my relationship with my family falls apart. Or if I don't take my medication, I have a much harder time staying in housing. And it's but just like Nick said, and there are definitely people, not everybody will, but there are definitely folks who are on orders who, if you ask them, they will tell you, hell no, I'm not taking medication. And so the 18-year orders are very unusual, but shouldn't be considered a failure on anybody's part. It's just what's needed.
And Amy, instead of splitting hairs, I'm agreeing with you. Insight, in the term one of the psychiatrists I worked with, he called it effective insight. And effective insight is, I need to take my meds to live with my family. I feel better with the meds than without. It may not be I suffer from a serious mental illness and I need this and that, but effective insight of I will continue to take the medicine without the court because I'm better with it than without it. And so yes,
We see
we call
eye to
yeah,
eye.
yeah.
Let's
So
see.
effective insight, whatever it is that drives a person to be adherent to treatment, and when you feel that they can do that on their own, that's when generally the prescribers in our court system will dismiss a civil commitment case.
Yeah, and this is a criminal court case, but when I use the verbiage AOT, it's because that's sort of the role. You know what I mean? Like the judge
Yeah.
has given these orders that this is what needs to happen. And so my role is to make sure those things are happening.
And I also want to say that's really unfortunate because you should never be put in that position. You're a family.
Yeah, but we don't have AOT yet. So
Well,
it's better than jail.
It's the criminal justice's
Yeah.
system's responsibility, and making you the gatekeeper or holding the keys to the jail, that just adds friction to what could be, what in some circumstances is an already fraught relationship. So, I mean, if he's got criminal charges, there are probation officers, there are pre-sentence hearing officers that should be doing that monitoring. They never should ask a parent.
Really? Okay. Well, he's 30. So I say parent, but yeah, I mean, he's an adult.
You're still the parent.
Right.
It should never be your responsibility to tattle on your loved one.
Well, but I am in Maryland, and we rank 50th in the states for the mental health, what is it? The danger to self and others law. Like there's, you're right, but it is always up to the family to put themselves in that position in Maryland.
And it's okay if you put yourself in that position, but a judge should never put you in that position. A system should never put you in that position.
A system, that's a good way to put it. Because I don't think the judge is intentionally doing it. I think they're trying to help keep him out of jail. But it in turn is putting that pressure on, our family.
Sorry, I feel very strongly about this, as you all can tell.
I need you in Maryland.
I just want to add that for our Johnson County program, our goals for our participants vary on the person. We have our first couple of admits were people that we identified that needed a higher level of care, and for whatever reason, the time wasn't taken to make that happen. So they came to us so that we could be a little bit heavier of a hand to force the system to do whatever they needed to do to get them to a higher level of care. And then we also have the participants that we know we will have for a very long time. Because like Nick said, they more than likely will never be able to have the insight to manage their mental health care without having that order. But we also very recently, we have a participant that after a year and a half has shown a great increase in insight, and we're actually, with the support of the doctor, are looking towards a discharge from AOT and a discharge of his outpatient committal order because he has fully embraced the services that have been provided and now has the insight to take care of himself both mentally and physically. So it's also really is dependent on on the person that you're working with.
Other comments on kind of the goals of AOT or questions maybe that came up for anybody in this discussion?
And while you're thinking, if you're new to if you're new, please introduce yourself in the chat.
I have a question that we're trying to really plan for and be mindful of as we're moving forward in our development. And it's in regard to the holding the provider kind of accountable for their part of the commitment and their involvement, and just any kind of thoughts or feedback on that. Right now, I think our plan is to use some, if an individual is already associated with a provider, helping them re-engage with that. But just thoughts on not letting a provider kind of get away with, oh, they're not engaging, we're discharging from service, or just really helping them feel like they're a part of the commitment as much as the individual in terms of responsibility to treatment, if that makes sense.
A probate court monitor is an advocate for treatment, and advocacy goes in two directions. It goes in advocating for the respondent to adhere to treatment, and it goes to the agency to be providing treatment in the best interest of the respondent. And it's kind of a 50-50 role. And and all monitors are in different positions, and they're in different, every program is so different. So in a generic way, I feel very strongly that advocacy is in both directions. And I advocate on behalf of my respondents for the agencies to provide better treatment. I was at a respondent's home today, and that person hasn't had a home visit by a case manager in 6 months. I'm going to the agency and saying we need to, this is not acceptable. Now the person is stable. The person is seeing their medical provider, but yet that's not acceptable. And on the other hand, we have cases where we have to help advocate to the respondent to be more adherent to treatment and to collaborate with the agency to make sure they're providing the best treatment. So it's a two-way street. You help in all directions.
Don't be afraid to use your connections in the community. We have had some struggles with providers, and whether it just be coincidence of a meeting with a certain person at HHS or kind of at a higher level that is able to help advocate for your needs. We recently brought up an instance of legal reports from the providers being copied and pasted and submitted to the courts. We have every chance we get, bring that to a conversation, like I said, with HHS or members of the court or higher ups in the provider leadership system to bring that to their attention and let them know that it is not okay and someone is looking and noticing. And I actually have started, when I do find that, I submit my own reports to the court, and I will include that in my status report to the court so that it is in the file, so that if it ever came down to reviewing their court file, that would hopefully identify, okay, maybe we need to go back and look at their last few legal documents to see if that is happening.
And I can add, Cindy, that I think this is not always possible, but that when possible, it's good practice to have the monitor be independent of the provider so that they can be unbiased in their monitoring or attempt to be unbiased.
Yeah, and I think that Brooke is the way we are leaning because we are fortunate enough to have a lot of providers in the county that trying to engage with what we already have established rather than an AOT team, if that makes sense, to have like the coordinator, liaison, monitor, to be that connection. So,
And that's smart.
Love that model.
I think we like our, oh, sorry, go ahead.
no, I was gonna say hopefully it can all work out like that with the support and yeah, just be independent, but helping kind of direct it through the providers that are established already.
I think that's really good for sustainability, because you don't want to stand up a whole big team that can't necessarily be sustained.
Right,
So
right. Yeah, especially starting out because we don't know what our populations, like, how many individuals will serve or be able to support. So yeah, good, very good. Thank you, everyone.
other questions, comments?
I have a question. For those programs that do not have an active judge or magistrate or referee, what does that look like if there does happen to be a program that doesn't have that?
Nick, isn't that Butler County? I mean, Butler County does 6-month reviews, but not necessarily check-ins in between.
Right. So I I guess in the sense that we have the same magistrate do all the hearings, so they do get to know people over time. So I don't know that I would call it an inactive judge, but they're not active in the way that Summit County, Ohio is, and other counties where there are regular, whether you call them review hearings, which is the term we use, or status hearings, or check-ins, whatever term you use is fine. And often in those counties, they'll do them weekly and then bi-weekly, then monthly. In my county, and this is where every AOT program is different, they hired a full-time AOT monitor and me, and in effect, I'm the face of the court in the community, and trying to help implement the court order in the community instead of in the courtroom. Different model. Different courts, different programs are different, but that's the way our county chose to do it. But I do think that because there is the same identified magistrate every 6 months, there is some continuity and a respect for the court, even though it's not as active as Summit County.
And that's where the monitor really has to be empowered. often talk about New York, who again implements statewide, but they don't use an active court model at all. It's not unusual for um, it's not unusual for uh, participants to not even show up for their hearings. So they may never have contact with a judge. But what they do have is they have a strong independent monitor who can uh, who can affect let's see, I'm trying to think of how to say this, that can get a pickup order or a temporary order of detention when someone is struggling. Or if it's the treatment team issue, again, they're seen outside of the treatment team. The monitor is outside of that and can say, hey, excuse me, hey, we really need you to step up either with a supervisor or and if you don't feel empowered to do that, perhaps your supervisor could do that. But I think keeping the treatment team engaged in this is the most uh, the most important thing a monitor does. And frankly, I'm confused a little bit about how you work things in Johnson County. They have case managers, correct? You don't provide the treatment.
Correct. So
Okay.
I'll be honest, things have gotten very confusing since they completely redid our mental health system.
Oh, yeah.
So our case management has changed of who does that now. So there's a lot of changes that are going on, and they're expecting more to possibly come. Um, and we're still, just because of the way things um, are kind of set up, we're still running into barriers between being able to um, have working with the judiciary and finding a smooth way to make that happen, since I am not a county or court employee. I am with a nonprofit. So we're finding that there's some nuances there too, because the judiciary like can't accept payment and things like that um, from a nonprofit. So we are currently working without an active judge. But we have so far, we have a liaison in the county attorney's office that is able to kind of fill in some of those gaps. And now that I am able to submit reports directly to the court as well, that has kind of helped fill some of the gaps. But we are still kind of looking at, will we eventually have to move forward in a um, kind of a not having that active judge, and are our two roles enough to continue to push the program?
Yeah, that's tough when everything is changing all around you.
Yeah, welcome to Iowa every 10 years.
Chad, I saw you went off mute. Also, I should probably be calling you doctor. Sorry.
No, no, I didn't have a question.
Oh, okay. Other questions or just topics for discussion?
Well, I have a kind of to piggyback off of the conversation they were just having is how does it work then if there's no judge involved? Like, isn't AOT assigned by the courts and then reports have to go into the courts and things like that? So how is it just the judge initiates it and that's it? I guess I don't understand the process.
So for us, it would be that we would not have a designated AOT judge. So if we, um, in Iowa, if someone is filed on their order for pickup and inpatient hospitalization gets sent and put on whoever's judge's desk happens to pull the short straw that day. It really does go on any random judge's desk. So that process is it runs on its own. Our particular program, it is an AOT program, but not everyone on committal is being followed by AOT. We're currently kind of working at it as a add-on monitoring and will provide transportation, but those are for only for the folks that get referred to us. So it's not an automatic thing right now. So our committal process runs freely without us. We can have input on our current participants and advocate and assist them with requesting the status hearings if they are wanting to challenge their committal. But ultimately, the court listens to their provider, not necessarily us. And that is because our program has only been around for 2 years, and we're just now starting to kind of get our fingers dug far enough in the dirt that more people are paying attention and listening to what we're kind of telling them about the individuals that we're working with.
But Kelly, to make it clear, assisted outpatient treatment is a civil court order. So it's always going to be initiated through the court system, and some court is always going to have jurisdiction over the participant. It's just that some programs don't have a judge who does what we call check-ins or status hearings. Like Nick was describing, his area doesn't. The area I came from had hearings, but not very often. So it was more led by the treatment team rather than the judge. So it still works. The treatment team is, essential in providing care, but there's still gonna be reports to the judge. So the judge, there will be a judge. It may be a variety of judges, but there will still be somebody overseeing the process in the court system.
Okay. All right. Thank you all.
And Kelly, I put two PDF resources in the chat. These are not necessarily, as we've kind of been talking about, every AOT program is different. And so in describing kind of different levels of judicial involvement, it doesn't mean that this will be how it is in practice everywhere, but just to get a better idea of kind of what Sarah's talking about. And then the other document is if people have heard of the black robe effect, you think of the judge when you think of the black robe, but the black robe effect is something that can be more, I would say, insubstantial than the actual judge, the court order itself and the power of that. So those might be helpful to you.
Yeah, thank you. It's great to hear all this because one of the issues we're hearing on the board is funding. So getting these ideas to take the pressure off the court system and their employees and see if it can be dispersed. So thank you so much, all.
Other questions?
I don't have questions, but wanted to take a moment to introduce myself. So my name is Freija Hukulak. I'm the Deputy Director here at Warren and Clinton County Adams Board. And sorry that I was late. Something occurred. Had to take care of that issue first. But really, I'm here to learn more. We have been considering AOT for several years and hoping that we could get to the implementation stages next calendar year. So just here learning and hearing what is happening and just kind of getting more resources available for our upcoming tasks.
Welcome, Rhea. That's really exciting. And the good news is Ohio has a lot of AOT programs. So
Yes, we
got
do.
people to visit and learn from.
Yeah, there is some familiar faces here in this school. So, but thank you.
Yeah, well, if people don't have other kind of specific questions, I think it could maybe be helpful to just talk about the role of the AOT monitor generally. What do you think, Amy?
Sure. Sorry, I got bug bites.
So I am going to share my screen briefly, and I will also put this document in the chat. Can you all see my screen? And I can see you. So, okay, I see you're nodding. So our team published this document fairly recently, this was this year, and it's kind of going through the different roles and responsibilities of AOT team members. Obviously, every program is different. And this doesn't mean that your program is going to be exactly like this, but I think that because the monitor is such an essential role, it's a good thing to refresh oneself on. And like I said, this is in the chat if you want to download a copy, but these are kind of what we see as the responsibilities of the monitor. And I'm curious if those AOT monitors who have been doing this work a long time on the call feel if there's anything missing or things that they don't do that someone else is responsible for. Because I think that that just showcases kind of the diversity of models. I guess I need to give you a chance to read it.
And it would also help to make
to
it a little
zoom.
bigger
How's
for
that?
for us older folks.
Okay, Amy. So my granddaughter does not allow me to say old. I'm half old. So For us half
Half old.
100 is old, she said.
Oh, well,
So you're
still old. I'm not 100, but not 50 either. Just curious, of those of you who are monitors, or are you having regular collaborator meetings or meeting regularly with the people involved or the organizations involved with the program?
In the beginning in Johnson County, I was doing fairly regular meetings with the providers. We usually do have like hab home providers or SCL staff or ACT staff that attend our check-ins every 90 days. So that's kind of a regular thing. But as for the more regular collaboration, it was very good in the beginning. And then as providers, have started to find out that or have realized that the accountability piece isn't just for our participants. um, we've kind of had some back off a bit and not be quite as engaged with information sharing and collaborative meetings.
I also want to throw out there that I hope that no one who is new to monitoring is looking at that list of responsibilities and thinking that's a lot of responsibilities because we're the main thing is that someone is responsible for most of those elements. It doesn't necessarily have to be the monitor, but they're important things to consider.
What is a typical caseload for a monitor? Like, I do all of those things for one person, and it's a lot of work. So I'm just wondering what the caseload for someone who does this on a full-time basis is.
So ideally, it would be a case manager who would be responsible for the outreach in the community, and the monitor would be monitoring that. So you kind of are having, sorry, I tried to visually represent that and it didn't really work. Uh, and I think our monitors on the call can speak to how many people that they have under commitment maybe, and how many people each case manager is really managing.
I mean, in my program, we have 108 people. Now, I'm not providing direct care, so I'm not sitting at Social Security with respondents trying to get signed up for Social Security or SNAP benefits. I've done that. I've driven respondents to appointments as a fill-in, but in general, the job is an overseeing role, an advocacy role, and it keeps me very busy, but moderately manageable, because again, the direct service is provided by generally 3 or 4 different agencies in our county, and I get monthly reports from the case managers for each of those respondents, and then I follow up accordingly. So that's our county, but I think this call, as most of these calls do, just represent the fact that all of our programs are different. And so each county is going to have a different type of monitor and a different caseload.
Yeah, we have, and Nick, every time we say your number, it gives me anxiety when you say that number every time. So we're smaller. We're Lorain County, Ohio. So we have about 19. And for us, we're like, yes, we're up to 19 people. But we really, most of our folks are under one agency, which is Rivian Mental Health. And so like they're scattered throughout, if they're probably for ACT, if they're with whatever case manager assignment, they do more of the day-to-day. But because I'm also our forensic monitor, so I have we meet once a month for AOT, and then I meet with them another time to just go over AOT and our forensic monitor, our folks there. So I'm meeting with them at least a couple times a month to review those folks and any other folks that we have, high utilizers, whatever the case may be. But they handle, like Brooke was saying, they handle, like the case managers do more of the day-to-day. I'm just making sure like that there's no issues, that, the compliance is there as much as possible. And they even do the reports to the court. Honestly, I just look over them because we meet once a month. If we were meeting less, I'd be like, Nick, like, hey, send me a report once a month, like I do with my forensic folks, but that's what we do.
And we in Johnson County currently have 13 participants, and we provide weekly face-to-face visits with 4 of those. The remainder are, have various other service providers, so I just gather information from them.
But as the monitor, Carrie, you don't do the face-to-face. You have a peer support staff member that does that primarily, correct?
Yes and no. Currently, so our peer support specialist just recently retired.
Oh.
So I am monitor and peer support specialist at the moment. So I am currently providing face-to-face visits while we're trying to hire someone.
Sorry about that. That loss is huge.
Yes, Patty was awesome.
Other questions, and great question, Kelly, by the way. I think that it was really helpful for me at least to hear kind of the range of numbers too.
Yeah, me too. Thank you all.
I just want to add that there is no correct number. Whether it's R108 or Ariel's 21, or Sarah used to be in Hamilton County with 250, whether it's one that you monitor, Kelly, or, hopefully the first person in your county's official program, every person that gets help from AOT is a person whose life is more stable. Carrie's 13. I mean, numbers don't matter. Programs are different sizes for different reasons. And hopefully there's an AOT program that is able to accept as many people in that county or jurisdiction that needs AOT. That's why they're going to be different based on rural county versus suburban county versus, urban counties. And it's just going to be different as long as the program is able to accept as many people as needed. We can do that in our program. Ariel's County hopefully just has a need for 21. And when number 22 comes around, they can add that person. Hopefully that's the way the programs are designed. And you don't need 108 people if you're in a small rural county that doesn't have 108 people who need it.
Totally agree with you, Nick. We're looking like we know people need the services and need the help, so we're ready for more folks. It's just kind of how the cookie crumbles. But yeah, absolutely agree with that statement.
Yeah.
This makes me think of something that a story that our former colleague Betsy Johnson used to tell. I think it was Betsy and not you, Amy, who said this, but it was talking about an initial collaborator meeting to consider implementing AOT in the community. And people were saying, who who would be in this program and how many people would there be, and that, you know, law enforcement had the same law enforcement, the provider, all of these collaborators were thinking of the same 15 people that they see all the time. I'm not doing the story justice, but the gist is that that those important collaborators who should be at the table know who would benefit from the program. Well, we're coming up on the hour, and this has been a really great discussion. I appreciate y'all's engagement and your time. Does anyone have any final remarks or questions, comments, concerns?
This has been very helpful. So thank you all very much for a county who's just getting rolling on this. So I really appreciate all the help and ideas.
Of course, and Amy just put our team email in the chat. All are welcome to reach out anytime with questions. And you will also get an email with this recording, so you can always just reply to that as well. Well, I'll give everyone 3 minutes back. And have a great day.
Thanks, everyone.